title of my talk is Focal Therapy for Prostate Cancer. Is it truly ready for prime time? And these are some of the learning objectives, and the outlines kind of model the learning objectives. So we'll go a little bit into some background and history of focal therapy, just for all those who might not be as familiar with what focal therapy is. As well, we'll talk about patient selection, treatment modalities, and what a proposed surveillance protocol might be, some of the contemporary outcomes and data, and as well as novel treatment and some advances in focal therapy. As well as I start reading more about focal therapy, of course, the whole idea of partial prostatectomy kept popping up. So I'll talk a little bit at the end about partial prostatectomies as well. Dr. Manis and I both have no disclosures for this talk. So as we all know, prostate cancer is the most common cancer diagnosed in men. In Canada in 2023 alone, there was an estimated 26,000 new cases, with an estimated 5,000 related prostate cancer related death almost. It's estimated that the 5-year net survival for prostate cancer is, up to like 91%, which demonstrate really high survival outcomes in the spectrum of survival outcomes that cancers can have, which makes it quite important. And of course, to look at, what risk category our patients fall into and what type of treatment modalities they might be eligible for. This is the PROTECT trial, the 15-year follow-up data that demonstrated that tried to get a better understanding of how low-risk prostate cancers should be treated. So they randomized over 16,000 men in the UK to active surveillance, radical prostatectomy, or external beam radiation. And it showed that really cancer-specific survival in this patient population that was heavily involved men with low-risk disease had very high cancer-specific survival. Metastasis-free survival was a little bit lower in the active surveillance arm. And this study did show that active surveillance is associated with higher disease progression and metastatic disease. However, it's important to note that this study, I would say, is almost getting a bit outdated, given the fact that now we're using a newer grading system of prostate cancer. As well, we're using MRI-targeted biopsies to diagnose less clinically insignificant prostate cancer. And when we look at active surveillance or treating low-risk prostate cancer and intermediate-risk prostate cancer, the treatment modalities range anywhere between active surveillance to whole gland treatment with radical surgery or radiation. When we look at active surveillance, the rates of active surveillance in the States went from 26% in 2015 to almost double that in the span of 6 years to 60% when there was a retrospective kind of EMR review of low-risk prostate cancers undergoing treatment at 350 urology practices across USA. It's thought that maybe focal therapy could potentially be this midway point between active surveillance and whole gland treatment in order to improve the benefits of active surveillance by delaying the negative consequences of treatment, but also hopefully not compromising cancer care by controlling these troublesome lesions that we find on MRIs and biopsies. And although we might think focal therapy is this novel new technology, the first mention of partial prostate treatment was actually mentioned by Dr. Hugh Young. This is a very famous American urologist. He's actually the one who developed the perineal prostatectomy, and the AUA, fun fact, has an award named after him. And he was actually one of the first people to mention partial prostatectomy. So this was an article that was published in the Southern Medical Journal in 1937, which is kind of crazy, where he talks about that he has shown in certain select patients that a hemiprostatectomy may be sufficiently radical, and that removal of half the prostate in which the carcinomatous nodule lies, along with its capsule and seminal vesicles and vas, may be entirely sufficient. Interestingly, there hasn't been too much more studies or papers described by him after this kind of mention, but it's interesting to see that this idea has been there, almost a century ago. Dr. Egner, when he gives his presentations, will kind of mention how evolution of focal therapy in prostate cancer kind of is 50 years behind that of breast cancer when it comes to lumpectomies. And I thought that's also an interesting correlation to see, how far focal therapy has come in quite in a very quick time span. So one of the bases of focal therapy is that there's this index lesion theory. We know from whole mount studies that prostate cancer is known for its multifocality. Anywhere between 60 to 85% of prostate cancer, or 2/3 of prostate cancers, will be multifocal. And with this heterogeneity, there are different tumors within the same prostate with varying characteristics, such as with varying size, aggressiveness, as well as behavior. It was thought that maybe in prostate cancer, there's this index lesion that is the primary or dominant cancerous lesion within the prostate that essentially will predict the behavior of disease. And this is the index lesion that leads to metastatic disease and has become truly the focus of diagnosis and treatment specifically, mainly in focal therapy. And of course, it's thought that this index lesion is the one that has the most number of mutations as well. Maybe it's thought that the residual prostate cancer in the non-index lesions does not compromise long-term disease survival. However, when I started reading a bit more into the index lesion theory, there are some case reports now being published of frequent clonal relations between metastatic lesions and actually non-index prostate cancer lesions, around 20 to 30% in certain studies. So I think if this is truly what focal therapy is based on, then I think we just need to make sure that this theory might be changing and it might not be as valid as we thought it was. Looking at some of the current guidelines, this is the AOA Astro Localized Prostate Cancer Guideline, and it states that focal therapy truly is still an experimental modality, especially in high-risk patients. It should not be offered outside of context of a clinical trial, and in intermediate-risk prostate cancer patients, that they do need to know that there is lack of high-quality data comparing ablation outcomes to radical therapy, surgery, as well as active surveillance. And there's a similar statement on the NCCN guidelines as well regarding focal therapy. So at the Society of Urologic Oncology meeting last year in December, they actually presented some of the preliminary findings of the Falcon project, which essentially aimed to reach somewhat of a consensus on focal therapy usage in prostate cancer patients. They had 244 participants who were originally invited to take part in this consensus statement, and the discussion revolved 148 participants. When we look at who actually participated, it's interesting to note that 20% of participants have not participated in focal therapy treatments, and I think that's very key because they can give, one arm or like a group of opinion that says maybe we shouldn't be doing focal therapy. However, the consensus group was made out of individuals who I thought were, high volume focal therapy urologists with over 30% them performing over 100 focal therapy treatments. As well, consensus was reached when they had 70% agreement, which I thought was a little low for trying to kind of come together with a collective agreement on what some of the screening or patient selection should be. So we're going to go over the Falcon consensus a little bit and some of the pitfalls and surrounding some of their statements. So when it comes to kind of genetic testing, as we all know, we're starting to do more germline testing in prostate cancer as well as somatic if necessary. The Falcon consensus thought that genomic tests from biopsy may potentially influence the decision to offer focal therapy, that patients with BRCA gene mutation should not be offered focal therapy with the thought that they might be harboring more aggressive forms of disease. They thought also that tissue genomic tests should not be offered to all patients prior to focal therapy unless, of course, we're concerned about those with a positive family history of prostate cancer or related cancer, etc. Originally, the studies all had kind of a PSA cap of, less than 10, maybe less than 20, to try and really select for those patients with less aggressive disease. However, the consensus thought that maybe PSA should no longer be a deterrent to offering focal therapy as long as patients have localized disease. As well, age, life expectancy, as well as lowering your tract symptoms were all thought to be not necessarily contraindications. Histopathology is another thing they tried to come to consensus on. They thought that patients with grade group 1 prostate cancer, if they agree with active surveillance, should not be offered focal therapy, which I think is great. Focal therapy can be offered to patients with localized grade group 2 disease if the percentage of pattern born is less than 10, even if they agree with active surveillance as an alternative, essentially. If cribriform pattern is present on biopsies, then focal therapy should be considered over active surveillance if that's the one that patient wants. They say that focal therapy can be offered to patients with grade group 2 prostate cancer with percentage pattern over 10%. That it can even be offered to patients with localized grade group 3 prostate cancer. However, it should not be offered to patients with grade group 4 and above. When it comes to lesions themselves, all lesions they thought could be safely treated as long as it can be safely reached by the chosen energy. And we'll go a little bit more into detail about them when we review some of the techniques. MRI and biopsy, local stage should be based on MRI and to not offer focal therapy if there's extraprostatic extension. Now, frank extraprostatic extension is much easier to see compared to when there's a concern for extraprostatic extension. So it really depends on, who's reading the MRI, their comfort, and it really should be kind of taken with a grain of salt if you truly feel that there's concern for extraprostatic extension or not, before offering patients focal therapy. At least 3 to 4 target and 10 to 12 systematic biopsies should be performed prior to offering focal therapy, and that it should not be offered if patients have negative MRI findings and positive biopsies. It could be offered to patients with multiple lesions, as well if positive biopsies are found in one of multiple MRI detected lesions, that focal therapy should predominantly treat the confirmed lesion only. They thought that the PSMA PET scan is not a suitable replacement for MRI, although it is being used to potentially follow patients as well to help guide some treatment, but there's no role for it currently in focal therapy. Now, with MRI, however, we do know that there are still some limitations associated with lesion identification. So this was a very interesting study based out of UCLA, published in 2019, where they looked at 588 men who had MRI prior to prostatectomy, who then subsequently had whole mount studies done at UCLA. And this was done with a 3 Tesla MRI, and the radiologist had read anywhere between 600 to 3,000 prostate MRI. So really, truly high volume prostate MRI radiologist. This graph was a little concerning to see because it showed that overall, even in this high volume center, they could only detect 45% of lesions that were present on the whole mount studies. And when we look here, we see that up to 22% of tumors more than 2 centimeters are actually missed on MRIs. So I think this just goes to show how, although we think we're seeing all these lesions, it's important to keep in mind that we might be missing up to 1/5 of lesions that are, more over 2 centimeters. There's also the size estimation limitation, where this is another study out of UCLA from the similar authors in 2021 that compared MRI to, again, whole mount prostatectomy specimens in 441 men. And they essentially found that the mean MRI volume as well versus the pathological tumor size was demonstrated that there was also almost a 0.8 centimeter underestimation in the true tumor volume. And the amount of underestimation was greatest for smaller prostate cancer, which again is a pretty big concern when you're thinking about focal therapy, when you're trying to decide your treatment margins and the extent of your focal therapy based on your MRI findings. So when we think about focal therapy, the kind of the textbook definition would be that it is an image-guided focus ablation of an image-visible, biopsy-confirmed malignant lesion plus an adequate safety margin. That's evolved a little bit now, where more so partial gland ablations are being used instead. So there could be quadrant ablation, hemiablation, which can be lateral or anterior, the hockey stick ablation, where this involves kind of destruction of all prostate tissue within a lateralized hemisphere of the prostate, as well as an anterior half of the contralateral region, as well as subtotal ablation, which just leaves the tissue around the nerves only. There are a lot of focal therapy technological methodologies out there. There's HIFU, cryo, PDT, a whole bunch more. And I'm mainly going to be focusing my talk on the top 3. mainly because they appear to have the most amount of evidence as well. PDT is the only focal therapy that has essentially randomized phase 3 RCT, that which we'll go over today as well. In the end, we'll talk about partial prostatectomy as well. So when it comes to treatment modalities, the Falcon consensus truly didn't really recommend any energy as opposed to other ones, as long as the energy selection is based mainly on the location of the tumor and operator's experience and what they felt could safely treat the lesion. Treatment extension, they thought that the minimal margin when treating the lesion can just be 5 millimeters, and the minimal safety margin of 10 millimeters is unnecessary. And they thought that focal therapy should not be performed if the lesion is less than 5 millimeters from the anal sphincter. And I thought that the mention that the minimal margin of only 5 millimeters being necessary from this consensus made us really question, does this group really know some of the newer data and things like that? Just because there have certainly been studies that show that you need at least a safety margin of over 5 millimeters, maybe 9, 12. And this is a study that was done by Dr. Taneja in New York. It was published in 2015, and they basically looked at 3D treatment margins based on MRI findings. So they compared prostate tumor boundaries on MRI, and then subsequently patients had radical prostatectomy, had whole mount studies again, and they used a software-assisted tool to essentially define an optimal treatment margin for achieving complete tumor destruction during this focal ablation. So in the panel A, you can see that there is this hypoenhancing lesion on T2 concerning for cancer. This is the treatment map that was mapped out by the MRI. And when they basically used this co-recognition tool, this was the actual true safety margin that would have been needed to completely treat 100% of the prostate cancer lesion on whole mount studies. And this is kind of the same thing, that's showing the same thing, just with a different prostate. Okay, so when we look at focal therapy techniques, there are lesions that you can treat for, there are therapies that may be better suited for anterior lesions, and there's thought to be lesions that are better treated for potentially posterior lesions. So for the anterior lesions, which are highlighted in red, it's thought that maybe HIFU, cryotherapy, PDT, and IRE can potentially be better suited for anterior lesions. For posterior lesion, HIFU, cryotherapy, as well as PDT and IRE can all be used. With HIFU, there's real concerns that it cannot really reach diameter. It cannot really reach areas more than 4 centimeters. As such, we would probably more so consider that HIFU is solely a posterior lesion targeting treatment modality. Looking at HIFU, what is it? So it's high intensity focused ultrasound. It's a transrectal probe with 2 transducers of varying set focal length. So this focal length is set by the machine itself at around 3 to 5 centimeters away from the transrectal probe, and it results in tissue heating of over 80 degrees Celsius, which occurs in this kind of right-shaped focal band measuring around 3 to 10 millimeters. Real-time assessment of tissue destruction is seen with ultrasound, although during the intra-procedural ultrasound, there's a lot of changes to the tissue, heating that leads to tissue expansion as well as mobility of some of the tissue. And so it's really questionable how much are we able to realistically see the treatment margins. With the heating, though, this causes thermal energy, which will damage tissue, leading to coagulative necrosis. And there's also mechanical effects of gas bubble formation during tissue heating, which then collapses and causes acoustic cavitation. So 2 different modalities in which tissue is being destroyed. And of course, the rectum is cooled down to prevent any thermal damage. And usually there's a catheter left in place for 3 to 7 days. And of course, this is done under general anesthesia. It's thought that potentially maybe larger prostates can be treated after transurethral resection or even cytoreduction. However, really, it's said that probably HIFU should not be performed for prostates that are larger than 4 centimeters in anterior and posterior diameter. This is one of the longest follow-up to date with regards to oncological outcomes after HIFU. was done at a single university center from 1997 to November 2012. And they looked at oncological outcome in a collection of 560 patients with a median follow-up of 15 years with a range up to 21 years. We see here that a lot of patients, 75% had Gleason 6 disease. So again, populations that's really enriched for low-grade disease. And, no focal therapy is no longer really being recommended for this patient population. When we look at kind of the success rates, though, however, it's a little discouraging to see that a lot of patients required retreatment. So when we look at overall survival, the mean age of the patient population was 48. At 15 years follow-up, 40% of them actually had passed away due to other causes. And when we look at cancer-specific survival, it showed that for low, intermediate, high-risk patients, for low risk, it was 95, 89 for intermediate, as well as 65% for high-risk patients. And metastasis-free survival showed essentially a similar curve. They also looked at kind of the salvage treatment required other than HIFU, and they found that up to 70% of men with high-risk disease required an additional treatment after, just getting this HIFU therapy. So it really does show that there might be a high rate of recurrence in men treated with this modality. When looking at cryotherapy, cryotherapy involves essentially induction of extremely low temperatures with subsequent thawing. Usually there are 2 freeze-thaw cycles down to -40 degrees Celsius. This is carried out through an argon-based cryoprobe that are placed perineally into the tumor under direct thrust guidance. The cooling results in essentially direct cellular entry and delayed inflammation-mediated mechanism of cellular destruction as well. And the tip of the needles that you can kind of see on this procedural ultrasound is where the ice ball is formed. And as we know, kind of from like radiofrequency cryotherapy for renal masses, while the area right around the cryopost can reach temperatures as low as -20 to -40, kind of on the outer shell, on the hyperechoic edges, the temperatures can only be 0 to -2 degrees Celsius. So it's very paramount that the lesions are actively being visualized and that the ablation margin is well beyond, and the ice ball is well beyond where we think the true tumor and safety margin is. Cryotherapy has some of the, I would say, the most amount of evidence, the highest volume, as well as some of the best quality data. So this is one of the older studies looking at essentially a cryo online data registry. It's called the COLD database, which consists of case reports of men undergoing cryoablation. A total of almost 1,200 patients were involved. At time of reporting this in 2008, the average age of men was 70. Median PSA was 9.6, and with a median Gleason sum of 7 actually in this patient population. And when they look at 5-year biochemical recurrence-free status for the entire population, as per the ASTRO or the Phoenix guidelines, essentially overall for the entire cohort, it was 71% of men for all comers were biochemical recurrence-free, as well as 72% by the Phoenix criteria. Looking at kind of like, again, functional outcomes, this group, again, also had a high proportion of patients with low-risk disease, as well intermediate risk disease, very few in the high-risk category, which is good. And this is also a study based out of a single center where they looked at a total of 260 men who received whole gland cryotherapy. They look at biochemical recurrence-free rate survival at 10 years follow-up. Although this says a 20-year follow-up, the median follow-up was more closer to 10 years. And the biochemical recurrence-free rate for all comers was around 84%. Failure-free survival, unfortunately, was only 66, so a high proportion then required additional treatments. And metastasis-free survival after additional treatments if they needed was 96%. So this is, in my opinion, one of probably the best data sets out there for what focal therapy could potentially be. This is a retrospective review of a prospectively maintained database at a high volume cryotherapy center in New York. And this is men with unilateral intermediate risk prostate cancer undergoing primary partial gland cryoablation in 2017. And they looked at a group of 132 men who had at least 2 years of follow-up. Biopsies were all undertaken for men at 36 months. When they looked at essentially 36 months, the estimated rates of freedom from recurrence in field was 97%, which I think is quite good. So it shows that maybe the recurrence-free rate survivals that were previously noted in previous studies might be lower because they might have been done for inappropriate patients, and they just might not have had adequate focal therapy. But it shows that, when done properly at a high volume center, recurrence-free rates at 3 years can be as high up to 97%, and this was confirmed on biopsy. Out of field, recurrences can still be up to 87%, and overall clinically significant cancer was detected in 86% of patients at 3 years follow-up. Similar authors also kind of looked at early functional outcomes following partial gland cryoablation. This study looked at 100 men, and they got them to fill out IPSS and SHIM scores 6 months prior to, as well as 6 months after cryoablation. And the mean IPSS score for the entire cohort decreased about 2.1 units, as well. The mean changes for the SHIM score was around minus 5.1 units. And when we look at it according to kind of what their baseline function was, there was some significant difference based on, what their, if they have mild LUTs to moderate severe LUTs, and no ED to moderate severe ED, and that kind of correlated to how much changes that they saw on their SHIM and IPSS score. And lastly, talking a little bit about photodynamic therapy. PDT essentially entails administering an intravenous photosensitizing agent called a ptyloporphin. This is selectively absorbed into cancer cells. It's thought that the abnormal vasculature leads to extravasation of this photo agent, and cellular destruction is mediated through basically inserting these optical fibers that are inserted transperineally into the prostate, again under trust guidance. And cellular destruction is only carried out or near areas where this photosensitizing agent is absorbed, which leads to reactive oxygen species formation, as well as vascular thrombosis and coagulant necrosis. This is the open label RCT phase 3 trial looking at PDT versus active surveillance, specifically in men with low risk prostate cancer. They included 413 men who were randomly assigned to photodynamic therapy or active surveillance, and this was only in men with low risk prostate cancer with total cancer core length of less than 5 millimeters. PSA was less than 10 with a PSA volume of less than 70 cc's. At a median follow-up of 24 months, all patients had to get repeat biopsies. They found that in the group that had PDT, there was a significantly fewer patients that had to progress to medium or high-risk disease in the PDT group. Kind of like here, so 28% for PDT group, 58% for active surveillance. As well, more men treated with PDT had negative biopsies, at 24 months, 49 versus 14% over here. When looking at the percentage of patients who require radical therapy was also demonstrated to be less likely in the PDT group, which makes sense because there was less progression. Okay. When we try to look at, overall, what might be the range of functional outcomes after focal therapies, this was a systematic review that looked at functional outcomes in over close to 7,000 patients. They included 26 studies on HIFU, 22 studies on focal therapy, as well as 8 studies on photodynamic therapy. And there's truly a wide range of kind of incontinence, erectile function, as well as fistula repairs you can see. For incontinence, overall, we can see that, a lot of men, over 90% of them will be pad-free. And this is mainly at 1 to 2 years after procedure. And for the erectile function, a lot of them would use the IUF score or percentage of baseline erectile function. Again, a very wide range of numbers, and that's most likely due to the fact that, a lot of the studies are still very heterogeneous. are very mixed. There's a lot of different ablative techniques out there, hemiablation versus focal HIFU, and treatment, of course, is tailored to the patient themselves. So there's no real guideline as to what these trials require. They just only grab the data, which is why I think there's such a heterogeneity in terms of their functional outcomes. Yeah. So looking back at the Falcon consensus, they thought that when we're following up these patients, that functional outcomes should be assessed every 3 months for about a year, and then yearly until stability. And that validated questionnaires should be used, such as the IPSS or IEF. When it comes to oncologic outcomes, patients should have PSA done every 3 months for at least a year, and then every 6 months afterwards. There's still no real consensus on PSA failure because a lot of things can determine what the patient's post-ablation PSA should be, such as how much of the prostate was ablated, what their baseline PSA was, to name a few. MRI should be performed every 6 to 12 months initially, and then subsequently on an annual basis, and patients should definitely have 3 to 4 targeted, as well as more than 10 to 12 systematic biopsies done within 12 months post-treatment to make sure that there's no histological signs of recurrence. And when we're looking at MRI-based treatment failure, it's thought that contrast enhancement in the treated lesion is most likely suggestive of failure after focal therapy with hypointense signal on T2 or signal combination of hypointense signal on apparent diffusion coefficient map with hyperintense signal on B values. Now, this was an attempt to try and see if there's a method that we can look at post-focal therapy MRIs in a more systematic way. So these authors proposed a prostate image after focal ablation or PIFAB grading scheme where it goes from 1 to 3, 3 being the MRI findings are concerning for cancer and that a biopsy should be carried out. And they essentially look at the, if there's contrast enhancement, what are the changes on diffusion weight imaging as well, T2 and on ADC values. Yeah. So this is an example of, excuse me, PIFAB1, where there was a lesion that you could see it's hypointense on T2 prior to treatment. You can see in some hyperintense signal on DWB value, hypointense on ADC with some contrast enhancement on DC right here. And post-focal treatment, you don't see any enhancement, and there is no enhancement on DCE. This would be a PIFAB3 lesion where there is concern of recurrence where you see this hypointense lesion post-treatment. This will be the pre-treatment map that shows that there's this hypointense lesion that demonstrates hyperintense signal on B value, hypointense on ADC, and there's some contrast enhancement. And still persistently after treatment, and this is at 5 years post treatment with HIFU, there's still some hyperintensity on DWI as well as some contrast enhancement on DCE. So all concerning for recurrent prostate cancer. And this is one of the biggest kind of systematic review looking at what some of the functional outcomes might be. And this looked at 8,000 patients. Again, just a truly wide range in biochemical recurrence ranging anywhere between 2 to 68%. So I would probably say that to date, we still have no real good understanding of what the true biochemical recurrence-free rate or success rates would be. I think some of the best data we have is from the cryotherapy that was done by Dr. Dr. Lepore that was presented earlier, because that does show that, in a high volume center, you can have, in-field recurrence-free rates of up to 97%. But I think that's important to keep in mind that it's a very high volume with select patients that were deemed appropriate for focal therapy. So what are some ways and new technological advances that are being proposed to improve focal therapy? Well, there's a thought that we can utilize AI to improve lesion targeting. So this was a very interesting paper published on prediction and mapping of intraprostatic tumor extent with artificial intelligence. So the authors trained an AI model inputting data from MRI, PSA biopsy, and pathology reports. And then they used and trained an AI model to essentially create a cancer estimation map or a CEM, which they thought would be the area that focal therapy should be carried out at. They then compared this to 50 patients who underwent radical prostatectomy and whole mount histological studies afterwards. And looking at this, the A panel demonstrates where the biopsy was taken and the MRI findings were of the lesion. The B demonstrates what the cancer estimation method was drawn out by the AI technology. And the AI draw this margin in pink. And looking at whole mount studies, we see that, in fact, the AI was able to essentially capture where the true tumor was when looking at this whole mount study. When they looked at 50 consecutive patients who kind of underwent the same analysis, they found that the mean sensitivity for cancer-bearing voxels as predicted on MRI was higher for the AI margins. Around 97% of cancer was included in the AI margin, as opposed to only 37% in the region of interest that was mapped out by the MRIs, which is quite impressive. It's thought that maybe we can also use real-time feedback with that can be done through imaging or histological feedback. So with real-time imaging, there is the MRI-guided transurethral ultrasound ablation, or TULSA. So TULSA involves a rigid urethral applicator with a transrectal ultrasound inducer. And the benefits of TULSA is that, you have the patient who is in an MRI machine that's looking at it, a real-time MR thermography, to hopefully give feedback on if you're treating the entire prostate gland, and then is the tissue getting enough thermal damage to allow for definitive treatment. However, the success rate still looking at this might still not be as good as they were hoping for. A single study looking at TULSA in 14 patients basically found that, in 29% of patients, so 14 patients had positive biopsies and still clinically significant residual cancer. So I think there's still some work that needs to be done in the TULSA field. Of course, Dr. Manis presented some of his work looking into application of simulated Raman histology. And this basically showed that when they carried out real-time intraoperative margin assessment during partial gland ablation of focal using cryotherapy, that treatment had to be changed in 3 out of 12 subjects secondary to positive margins. So I think these are ways that we can hopefully improve treatment margins, because we're able to get real-time feedback to treat more, or even offer whole gland treatment if we feel that we're not able to achieve adequate treatment margins. And of course, there is another set of tools being used, which are gold nanoshell coated particles. So these are aeroshells, which are comprised of thin gold shell deposited around the solid silica core. This is infused into the patient's bloodstream around 24 hours before they undergo photothermal ablation. And it's thought that this gold particle shell will essentially be passively accumulate in the tumor perivascular space secondary to aberrant endothelium around tumor. And as this extravasates to around tumor cells, when the light is applied, again, transrectally under ultrasound guidance, you can see that the thermal energy is mainly applied to the areas with the nanoshells, only hopefully limiting destruction of tissues, benign tissues. Yeah. And we'll talk very quickly a little bit about partial prostatectomy, which is being described as an alternative to focal therapy to manage low and intermediate risk prostate cancer in very select patients with appropriate tumor location. So Dr. Villers, he's a urologist in France. He's done quite a number of these, and he looked at 28 men who underwent robot-assisted anterior partial prostatectomy. This, of course, only involved men who had anteriorly located tumors or tumors that were mainly partially located within the anterior fibromuscular stroma. Median follow-up was 7 years. And what they essentially do is they go in through the traditional robotic prostatectomy method intraperitoneally. And once they get to the prostate, they essentially only take out the anterior portion, and then they reanastomose the new bladder wall directly onto the remaining urethra. And this is kind of what it looks like afterwards. They found that recurrence was present in up to 29% of patients at 7 years of follow-up. However, they did have uninterrupted continence in 92% of men. So when catheter was removed, 92% of men were completely continent with uninterrupted IEF scores in 13 out of 19 men who had IEF scores more than 15. Unfortunately, the study showed that 36% of patients after the procedure had positive margin rates. So probably still very experimental, but an interesting study nevertheless. There is also reports of single port robotic transvesical partial prostatectomy for localized prostate cancer. This is now being done at a Cleveland clinic, and they looked at 9 patients with low to intermediate risk prostate cancer. Very interestingly, these patients are discharged on post-op day 0, which I thought was very cool. They perform intraoperative surgical margins. There's 100% continence rate at 6 weeks. As well, median shim score went from 23 to 17.5 in these patients. So this is, and depending on where the location of the tumor is, it's kind of where they'll carry out their dissection. And these are just some intraoperative images. So this shows how they're going to dissect out the bladder neck. This involves, and then they dissect out the seminal vesicle. This is a left gland tumor, so then they're doing a left hemigland excision. They're doing margin assessments. It's not really demonstrated here, but they actually pass transperineal biopsy probe as well as transperineal biopsy needles are passed through the perineum to actually get margins, and then the bladder neck is sewed directly onto the urethra. There is also precision prostatectomy, and this was published in 2021, that looks at essentially and this is considered a form of focal surgical therapy that allows radical excision of the index prostate cancer lesion with over 90% of prostate tissue that is around that focal lesion, while preserving the prostatic capsule and seminal vesicles and vas on the contralateral to the dominant cancer lesion. They looked at 88 patients with a median follow-up of 25 months. They found that 100% of men were continent or using 0 to 1 pad per day at 12 months, and the median time to continence was only 1 month. They found that 90% of pre-op potent men were able to be potent at 12 months, so really good continence and kind of erectile function rates. Again, positive margins, had focal positivity in 20%, 23% of men, and non-focal in 19%. So over 40% of men with this procedure also had positive margins. So I think the idea of partial prostatectomy is really interesting, but with the significantly positive margins, I'm not really sure if this is something that I would necessarily say would be recommended, especially for men with high-risk prostate cancers. So in kind of summary, we went over kind of where prostate focal therapy for prostate cancer came from, where some of the evidences and some newer techniques. There still exists some major limitations in the field. MRI can definitely miss significant lesions and underestimate the size of lesions, leading to undertreatment. There's still a lack of randomized control trials, especially when comparing to whole gland treatment, especially if this is being proposed as an alternative. And there's still a lack of standardized protocol defining recurrence, failure, surveillance afterwards. Although the Falcon consensus aim to achieve this, there are some concerns regarding validity of some of the statements, especially the treatment margin, I think was a bit too small. Like probably treatment margins should still include up to like 9 at least millimeter based on that study. And that was kind of it. So thank you everyone for your time, and thank you for listening.